o'clock. So we will go ahead and get started. As I said, my name is Martha Acklin. I'm one of the Clinical Improvement Advisors with the Hospital Quality Institute, and I'm here today to welcome you to our third seminar in our Falls Coaching webinar series. Our focus today is on proactive toileting and toileting prior to pain medication. I want to thank all of you that have been with us. We've had great participation at our previous webinars, and we are excited that you're all here again today. I do hope everyone had a nice, healthy and happy and festive holiday weekend. So, next slide. Wait a minute. Here we go. So, I want to, as we get started in the webinar today, I'd ask you to who's in the room. So I'd ask you to identify what your relationship is and just click it in there so we can get a feel for who's joining us today. And as we're doing that, I want to give a reminder, and the reminder is that all the lines are on open, so if you please don't put us on hold, because if you put us on hold, then we'll get to hear endlessly your hospital's music. And the other thing, I also wanted to give you a reminder that this program is eligible, you are eligible for CEUs from the BRN, which also are applicable towards your CPHQ and your ACHE recertifications. So the webinar link for that is in the box right below the webinar. So just be sure that you use your full name, email address, and license number in the evaluation so that you can get the credit. All right, so it looks good. We've got a lot of people from management, a couple of senior leadership, and then 3 other people. So thank you all for joining us today. We appreciate it, and we will continue. Just to refresh your memory, the goals for this Falls Coaching webinar series is 1, to extend the application of fall and fall injury prevention interventions to specific populations. 2, to restate the critical program elements to reduce repeat falls and preventable falls. And lastly, to help you to compose strategies to reduce barriers and enhance facilitators to short-term and long-term program implementation. Oh, yes, I will do that. Oh, mine are on mute. Shweta, mine's on mute. Oh, now I just took it off. I apologize, folks. I got distracted there. So what I wanted to ask, or what I would suggest is, while you were on the webinar, if you have any comments, you can go ahead and type them into the chat box as we go along. The next slide is just gives you an overview of where we're at. So today is session number 3, and as I said, we're going to be talking about proactive toileting and toileting as it relates to pain medication. As you may recall, in session 2, we talked about protecting patients from injuries when they fall and the role of the unit-based champions. I'd like to ask you to chat in what experience you're having with your unit-based champions. If you've identified some, how that is going, or any barriers that you might have, and we can speak to that as we go along. And then on the first webinar, as you may recall, we talked about post-falls management, the huddle, including the patients. We got a lot of good feedback last time from different hospitals that they're including patients in the post-fall huddle, and how enlightening that has been, that the patients really appreciated it because it helped them to understand really just how we're focused on safety and how you are doing everything you can to keep your patients safe. So I have a couple more polling questions here for you. And this polling question number 2, was going to build on some of the things that you learned from last time, and that being that identification of patients for high risk for falls. We talked about 4 different things that can influence the patient's risk for injury, and they're the ABCS, and there are a bunch of different options there. And I'll give you 1 more or 10 more seconds to vote. And so, Pat, I think that it's pretty clear that people got the message.
Got the message.
Yes.
Right, got the categories. Good job, everybody.
Yeah. So age, bones, anticoagulation history, and surgery can all be influence the patient and put them at high risk for falls. Great. Thank you. So then our next polling question, where the last time we also talked about the unit peer leader or the champion role, and so the polling question is the unit peer leader or champion role includes A, conducting all post-fall huddles. That champion conducts all the post-fall huddles. The champion is responsible for sharing unit-specific fall reports at team meetings. The unit champion has had a family member with injury, or the unit champion is a resource for questions on preventing falls with injury. So, give you a couple more seconds there. And honestly, B and D would be both of those answers are correct. We one way to engage the unit champion is to give them a specific role at the team meetings to share about the fall reports on that unit, and also to be a resource to their colleagues for any questions as they relate to preventing falls with injury. It's important to note that the champion isn't the only one that knows how to prevent falls with injury, or isn't the only one that conducts post-fall huddles. These are ongoing strategies, and so everybody is going to have some knowledge, but the champion is really the resource for the unit. Great. So takes us on to our next slide, and with that I want to introduce and hand the program over to Pat Quigley. As you recall, Pat is a PhD nurse consultant that's working with us. She was with the Veterans Administration for many years, and she was the Associate Chief of Nursing for Research, and funded researcher with the Research Center for Excellence. She is seen as a subject matter expert on falls and preventing injuries from falls at the national level, and is nationally known for her program of research in inpatient safety, particularly in fall prevention. So with that, I'd like to turn it over to you, Pat.
Thank you so much, Martha. I'm just so glad to be with everybody again. And I want to thank Shweta so much, too, for all that you've done. Shweta's on the call, and Krishna, who's done so much work to help us, Krishna, for setting all this up. But, colleagues, I hope you had a wonderful 4th of July. It was such a special time for us to say thank you and to appreciate where we are in the global world and all that we're doing with patient safety for people who come into our care. And I love this topic of talking about how to be able to keep people safe when they're in our care associated with clothing. And why did this emerge as webinar number 3? Because for those of you who got to be with us at the conferences, this was one of the top initiatives that people said that they were going to go back into their organizations and do something about, do something different, as we got to share. So I do look forward to talking with you about proactive toileting, you know, looking at bedrooms, bathrooms versus bedside commodes, and then toileting prior to medications, which is one of the things that we've launched for a long time in the VA. 2 risk factors that we know, people getting pain medications and having to toilet, and then when you put the 2 of them together, it really makes it just an incredible combination of risk. So let's go ahead and get started. You know, so many of you I know are doing work in safe patient handling and movement. So I'm going to do a little bit of connecting to safe patient handling and movement to falls associated with toileting at the point of care, because this does have to do with patient handling. It has to do with the actual task of toileting. So can you hear me okay?
Yep.
Oh, good. Okay. I thought I heard someone say Pat. So, you know, this does have a little connection. So maybe some of you are doing this. So when you think about patient handling and trying to get people to and from the toilet, it does involve knowing how to appropriately transfer patients, how to get them to a sitting position from a lying position, how to help them get to transfer if they're actually just doing a transfer to a bedside commode. Maybe sometimes we're using slide boards to help with transfers, but also how to get people on and off the toilet. So it does, patient handling is an important component of toileting programs. And then you have the ADL tasks that are associated with toileting, indeed the transfers, but how do you manage the clothing? And then how do you help people be able to clean themselves, wipe themselves, manage all of their personal hygiene? So it involves activities of daily living and then redressing as well as grooming and bathing. So there's a lot of patient handling activities that are involved when you're addressing toileting. So there's a lot of ergonomic exposure associated to you, the caregiver, and those around you who are helping with the toileting component and activities of daily living. As you can see in this quick picture, we do a lot of bending and twisting and lifting, crouching and reaching for things. We have static postures where we're just holding someone even while we're trying to help them sit down on the toilet. Sometimes you have slippery floors that we have to deal with, and how do you manage that? And then you've got high forces, the forces of trying to lift someone back up that can be somewhat repetitive for us. You've got, and then of course, repetition of getting people up and down, up and down, up and down. But the high forces of lifting are really important. So this should always be considered when you're looking at your toileting program and how to be able to individualize the needs for a given patient. So what do you do differently for someone who's dependent on toileting? For these patients who are dependent, you can often get slings to help with this, with a dependent lift. Of course, you'll have to have a larger access area to help navigate this patient on and off of a toilet. You'll have different selection criteria for the standard versus standard dependent slings that you'll be using when you're using the toileting type of a sling. There's also equipment that you might need to have for sit-to-stand to be able to help people be able to balance. And then you consider the access that you have as well as the patient to any kind of equipment needs that you need to have in place of toileting. Then there's the toileting where you have people who are dependent in terms of weight bearing, depending on how much weight bearing they have. You might have a standing and raising aid that can help you be able to get someone to a standing position depending on how much weight bearing. Some of them are battery operated or non-battery operated. Then there's considerations that you consider for people depending on their weight bearing status, how much assistance they need to actually stand, their ability to access their perineal area for self-cleaning or managing their clothing up and down, as we mentioned, donning and doffing, and then getting on and off the toilet. But depending on, too, the extremity that has limited weight bearing, whether it's toe touch weight bearing or partial weight bearing, you're always transferring that patient towards their unaffected side, their stronger side, so that they can be able to manage their balance and be able to help you with that transfer activity. But we need to know their weight-bearing status. Toe touch weight bearing, they can only put enough weight on their big toe, as if not any more than it would crack an egg, if you will. It's just to have some sense of proprioception, to know where that leg is in relationship to space. whereas partial weight bearing is oftentimes what they can tolerate. So knowing someone's weight bearing status when they're trying to help someone even get out of bed, but actually transferring to the toilet is really important. And indeed, it makes a difference in knowing and navigating your bathrooms, because bathrooms have fixed equipment in there. So how do you navigate this when you have someone who maybe, if you will, should be transferring always towards the right side, and it's a very closed environment for them to be able to navigate this area. So when you're looking at caregiver assistance to you, there are standing and rising aids that people can have, some of them that are battery operated. There's a lift device that you can see here, the lift that provides support and also helps with the hygiene needs of the patient. Some of the lifts will allow the patient to participate in the hygiene, and some of the patients will still need to have some weight bearing. So they can allow some of that weight bearing during the lifting activity. And then the patient can also, for some of them, be able to pull up a bit and be able to do some of the standing. There's all kinds of different equipment out there when you look at safe patient handling and movement to help with clothing. But what we don't want to do, what we try and move away from, is this whole issue of a bedside commode. So what is the difference between having a bedside commode versus having, if you see in this lift, the patient here is in the sling, the patient's able to hold on. You've got all kinds of equipment to be able to assist this patient, and it's pretty secure. It's got locks on there on the brakes, and you've got the wheels. In the bedside commode, which is oftentimes our alternative for dealing with and toileting a patient on a toilet that's too low and has insufficient grab bars, we end up putting a bedside commode over the toilet, and this is not stable. You know, they move, they're not secure, and even if you look here at how little armrests are available on this bedside commode, you also have to height adjust it. So it's not like you can just use one height for all patients. So when you're looking at the different kinds of equipment that's available, there are different aspects of selection when you're looking at what to use to be able to help you with your lifting and your mobility of patients to help with floating. So what we don't want to do is to be able to have to navigate in this picture. So if you look at this bathroom, what you see is a toilet that's extremely low, very low, for anybody to be able to get on and off of. And this is really important. This is like why it's important to do a mobility assessment if you're actually helping people get on and off a toilet. You know, how many of us orient a patient to a bathroom as part of their admission orientation to see if they can even get on and off of a toilet safely? And what kind of equipment do we really need to have to help this patient? If you have someone who's deconditioned in their lower extremities, if someone was trying to sit down onto this toilet and it's too low and they're deconditioned, what's going to happen is if they can, they'll be holding onto that grab bar that's too far away on that right wall. If you can picture the patient facing forward from the toilet, they would be holding onto a grab bar that's too far away. The toilet's too low, and if they're trying to sit down, they have nothing to hold on to on the left side. So someone would fall onto that toilet because they could not do a controlled lowering to that toilet. And then picture this. If the patient was trying to get up, the toilet's way too low, and the patient's trying to get up, that grab bar on the right wall is so far away that the elbow is away from the body. You can't even use your biceps and triceps to push off to help compensate for legs that are too weak. So the patient would be trying to lift up, trying to get to a standing position, and would maybe make it so far up it would fall back down. Or even worse, maybe lose their balance and fall off to that left side of the bathroom. So you can see how dangerous this is. If someone also fell backwards, they'd be hitting that grab bar to the back of that toilet as well as the plumbing fixtures that are there. So you can have someone hurting their back, maybe hitting their head, depending on how they actually fall down. So this bathroom really makes you worried. The other thing I want to point out, too, is if someone lost their balance and started to fall to the right side, they would hit that one grab bar. But look at where the toilet paper holder is. It's right underneath that, so they can't even have a really good grasp of that grab bar and be able to use it successfully. The grab bar that's still on the right wall, that is on the vertical plane, not horizontal, but the vertical plane above the one that's on the horizontal line. If you had someone even holding onto that, trying to pull up, if they got a little bit up and started to pull, then you worry that someone's going to really lose their balance, because you never want people to pull up on something that they're sitting on. They should always push off and hold on to sit down, because that way they don't lose their balance and fall forward. So as you can look at this bathroom, there's so many things that make you worried. And so think about this picture, and maybe you'll do a walkabout in your unit and some of your bathrooms in your waiting areas, and I bet many of your bathrooms look like this. So how can you really make this different? There's a little picture underneath the sign that says this is a male-female, a unisex bathroom that has the restroom room sign on it. That toilet that you see there has a little adjuster underneath it that sometimes you will see in some of the bariatric fixes to toilets that are too low. But you can almost see that there's a padded seat on that chair, on that toilet, that now starts to raise that toilet up just a little bit. So what are we looking for when we're trying to make bathrooms safer? And this is fixing the environment still. So when you're fixing the environment, you're reducing that accidental fall. So you do want to have raised toilet seats that are indeed installed on the toilet. They're more secure, much more secure than having a bedside commode. But then you'll see on to the right of this picture that now you have one of those drop-down grab bars. And this should be on both sides of the toilet, but it should be close enough to the toilet that people have their elbows close to their body so that they can push off to stand up and hold on to sit down, compensating for weakness in their lower extremities, if you will. But this is now getting better. You know, when you start looking at having a raised toilet seat and then getting people the proper equipment to be able to get on and off the toilet. This picture shows it even better, where you now have a toilet seat that's a little bit higher, but you've got the drop-down grab bars that are on either side of the toilet for people to be able to hold on to get up and be able to hold on to sit down and push off to get up. Then the other thing that you can start seeing is how stuff is cleared away from that bathroom. So this is truly getting to the point where we're creating a safe environment in the bathroom. And why is this important, colleagues? Because falls that happen in bathrooms are grave. You want to do everything you can with a toileting program to look at the interface of the patient in the bathroom to make sure that if they were to fall, that you're reducing the risk of having a serious injury. Because they're closed environments with lots of hard surfaces for people to get injured on their way down. And when we did the polling question, we had senior executive leadership on this call and management. You know, these are things that sometimes take more time to be able to fix, to be able to install proper equipment, but this should be part of strategic planning. When you think about, if you will, creating a safe environment for older people or people who are debilitated, or even think about new moms trying to get on and off of a toilet. If they don't have these proper grab bars, it makes it harder for them to get on and off a toilet. So creating a safe environment is one of our first priorities when we're looking at any of our patients' safety work in relationship to fall prevention. So what we like to do is to just have you do a little bit of sharing. You know, what is your experience with staying with patients within arm's reach while the patient is in the toilet? You know, what factors do you consider before leaving a patient alone in a toilet? And any lessons that you have that you've learned to increase adoption and spread related to safe toileting and looking at a safe bathroom. So we'd love for people to do some sharing and a little bit of chat there. We'd love to hear from you. So we have someone typing for us already.
Yeah.
And I'm still going back to this other picture where you had, where it makes me worried, is when you look at all the metal that people can hit. You know, just anything you can do to create space and make it safer.
So Zora, I think Zora added a nice comment there, Pat, about oftentimes the patient does not want someone to stay with them. And so that's what Pat is going to be going into next. So I appreciate you sharing that because I hear that from clinical staff that I've worked with. And I think that, you know, it comes to the point where we want to really help the patient understand that their safety is our primary concern. But again, that's easier said than done. We understand that, and Pat will talk about that a little bit more.
Absolutely.
So, all right.
And so I see, lots of people are talking about the no one toilets alone, and we will talk about that. But I just want to mention too, Eileen, thank you so much for sharing about your policy. The issue with making a decision based on low, moderate, or high risk is what you want to think about rather than a category of risk is what's their ability to be able to safely transfer on and off a toilet. So if you have someone who's cognitively intact and functionally independent and is able to know their risk of going into a bathroom, and that's why part of what I mentioned in the beginning is you actually do an assessment to see how someone can do getting on and off a toilet. So if you have someone who's functionally independent and cognitively intact and they can get on and off a toilet fine, maybe this is someone that you're going to be okay with leaving them in the room by themselves. But at least you've been able to evaluate that they can manage this. It's very different than taking someone in there. I mean, think about this bathroom again. If you had a patient here who was a right brain CVA that had right side strength but left side weakness, this is indeed a bathroom that you would not leave a right brain CVA patient in the bathroom alone, because if this patient was to get up without you, would fall indeed over to that right side. So it's still a matter of being able to actually individualize care. So it is important to be able to assess their ability to get on and off of a toilet and think about, their mobility needs and any other kinds of equipment. I will say one more thing about this bathroom. You can see if both of the grab bars were down on either side of the toilet, this person would have safety rails, if you will, on both sides, and you're helped to reduce the risk of someone losing their balance while they're sitting on the toilet. So this is always important when looking at creating a safe environment. So thank you, colleagues, for all of you who did do some sharing for us, and still trying to look at ways to be able to consider what are our approaches. So the logistics of a toilet, you have to, when you're thinking about what are you going to do, there's some things that are similar, but other things that are different. So, the logistics of it is you have to determine, if a patient determines is it time to go, does the patient decide whether or not to use a call light and a call bell or not? So this is what we want to think about in using a call bell is how long will I be able to wait, or will I wait? And, you're going to wait, or you're going to get up and go. Or do I not use the call light? So should I use the call light or should I not? So sometimes what you have to do is to have this conversation with patients. And this is why we wanted to ask, how do you really manage this, implementing your policy where no one goes to the bathroom without you? Because there are patients who you all know have gotten up and gone to the bathroom without you. And we didn't do an evaluation to see if they can manage the toilet on their own as part of the orientation once they got settled in. So how do you have this conversation? How do you help a patient be able to really think through this? And mind you, this is for someone who's cognitively intact. So for someone who's cognitively intact, you want to have a conversation about why it's important to call for help. What happens, what are the consequences of choosing not to call for help? And what could happen to them. If they were to get up and go without you, they could have an accident. That accident is a fall, and what could be the consequences of it. But still, having this conversation, will I call for help or will I not call for help? And then there's this whole issue of privacy versus independence. And I think this is where you oftentimes will get into some really rich discussion with patients, because there are times where privacy trumps safety, and there's times where safety trumps privacy. For someone who is cognitively intact, and they can demonstrate in terms of the teach-back, they can tell you why they're at risk for falls, what are we doing to help prevent falls, why it's important to call for help, and what's the consequence of a fall. What would happen if they were to have a fall? They can talk to you about and be able to help you with mobility. They're able to rise to make sure that they're able to get up and they're functionally independent. But for people who have supported mobility, are you able to raise the bed up to the proper height for them? Do you make sure they have mobility aids within reach? This is something we should all be doing, and making sure they're getting up from the bed on the correct side, the side that is their safer side. Again, having adaptive equipment within reach, and if they have proper footwear, and it's not just non-skid socks, so it's proper footwear, and then of course the grab bars that we just talked about. So you want to be able to have them demonstrate, that they can get up, how safe they are getting up. This is that mobility component. But you want to make sure that they understand why it's important to call for help, but why they're at maybe greater risk while they're in the hospital, because maybe they're taking some medications they haven't had before, they're having some procedures done they haven't experienced before, and it's a different environment. They wake up in the middle of the night. It's going to be a different kind of environment. So it's always important to really be able to weigh and make sure we're having those right choices to weigh the privacy versus independence, the safety versus privacy. When safety is really trumping privacy, this is when you're really dealing with people who are cognitively impaired. You are going to, you want to be able to protect them. So with people who are cognitively impaired, we want to do everything we can to keep them safe, because they can't be a full partner in your fall prevention program. Patients with cognitive impairment, you want to make sure that you have them on a scheduled toileting program. These are going to be people who need to have assistance with toileting, or they're going to be on a bladder retraining program. And these are also going to be patients that you're going to use that scripting for, or have some way to be able to make sure everybody uses the same language with them. So I'll give you an example of the scripting that we did, especially for people who need to be on a scheduled toileting program, because they have some memory problems and they have some incontinence issues. So we really need to help them with a scheduled toileting program. So what we would talk to them about, when we would go in and you have them on the training program every odd hour, every even hour, because you're not going to take every patient to the bathroom every hour. But people should be taken to the bathroom on a 2-hour rotation. Depending on when they stop having their fluids at night, you're not going to be taking people to the bathroom, of course, every 2 hours at night. So you might stop fluid intake around 8 p.m., for example, so that you're not getting them all the time at night and have the last toileting maybe around 10. But still, if you're staying with me on this, when you go into the room, what you want to say to the patient is, do you want to go to the bathroom now or 1 minute from now while I'm here, because I want to help you? So that's a very nice way of being able to give the patient choice, but they don't have a choice for no, if you will. So by giving them that kind of a choice, you're able to help them appreciate that, this is something we want to do. We want to help them while we're there. And that way you know that we were able to get this done. Oftentimes we go in and say, do you need to go to the bathroom? And they tell you no. And you know this has happened. You leave the room, and 10 minutes after you've left the room, they're getting up and going without you. So again, on the left side of this slide, there are times sometimes where privacy and independence can trump safety, but there's other times where safety is actually going to trump privacy, because safety is all about being able to protect people. So it is different when you're dealing with people who are cognitively alert and functionally independent, or maybe cognitively alert and maybe need some help with mobility. Those are going to still be patients who need to have assisted toileting, but they're not patients who are going to be trying to get up without you or don't understand their consequences of their choices because they're cognitively alert. So that's why you want to have such a different conversation with these patients related to the teach-back, to make sure that they understand, again, their fall risk factors, what are we doing about it, why it's important to call for help, and what happens if they choose not to call for help and they have an accident, that accident is a fall. So these are very different approaches when you're dealing with people that are cognitively alert versus people who are cognitively impaired. So, the million-dollar question is going to be, how do you help really keep people safe? What part of toileting is unsafe for this individual? So you want to have this conversation with people. Are people going to call you for help or not? So the accidental fall risk factor is going to be people who trip or slip on something, and they have hazards in the environment or medical devices and equipment that are not appropriate for them. Maybe you have sequential compression devices on people with cognitive impairment and could get up. Those are the patients that I like to suggest that we put them on TED hose, because that's contraindicated. If you know people are going to have cognitive impairment, they're going to try and get up to go to the bathroom. You don't want them tethered to the sequential compression devices. Or if they've got IVs. So you have people who can have these accidental fall risk factors. And then you've got the anticipated physiological fall risk, people with postural hypotension, people with poor balance, people that are weak, or they've got medication-related issues that are contributing to confusion, maybe having some ataxia, they're making their increase in their loss of balance. So when you're considering all of the risk factors associated with toileting, it becomes so complex, colleagues. This is why it's such an important topic, is to really drill down what is making this patient at risk, because everyone has different fall risk factors. So you want to know, are you doing everything you can to keep this patient safe, creating that safe environment? Then you reduce those accidental fall risk factors. To work on the anticipated physiological fall risk factors, you've got to work people up. So this is why it's still important to know what medication someone is taking that has postural hypotension as a side effect. You need to see what their balance is. What's their sitting balance? What is their standing balance? Can they feel their feet? Do they have trouble with foot placement? You want to know if they're weak. You want to know what kind of medications they're on. Are they on a diuretic? And if they have a diuretic, have you been able to work with your physicians and your pharmacy committee to make sure that diuretics, if they're BID, they're given at 9 a.m. and 5 p.m. and not 9 and 9. You know, there's lots of things that we can do to be able to adjust this risk. The anticipated physiological fall risk factors that you see here, the postural hypotension, the poor balance, the weakness, those are intrinsic risk factors inherent to the person. The only way you would know them is to do a physical assessment, an actual, you'd work them up. The medication-related risk factor is an extrinsic risk factor, is outside of the person, but it's something we give to them, and then they can have the side effects. So when you start looking at what is unsafe for an individual, and then they fall, this is where it's really important to do this post-fall huddle. And we've spent time on the post-fall huddle. The post-fall huddle is where you get the information about why a patient fell. So even if you look right here on this slide, the risk factors, and think of all that we've talked about already related to the environment, every one of the things that we've talked about could have been a reason why someone fell. So you could have someone fall on the way to the bathroom and on the way of getting up in the bed, walking to the bathroom, trying to get on and off of the toilet. Maybe they had got dizzy on the way. Maybe they had some balance problems. Every one of those risk factors, colleagues, could be the reason why a patient fell. But they have so many risk factors that contribute to that fall event. But here what we're talking about is trying to get to the reason why someone fell. So this is what you would be trending in your data when you're looking at the post-fall huddle associated with toileting. So you should be able to break it down when people have falls associated with toileting is what happened? What protective barrier actually fell through? So again, with the environment, when you're trying to create a safe environment, what you really want to do is to look at, is your environment as safe as it can be? Do you lack the proper grab bars? Are you using a toilet frame or a commode over the toilet? Are the toilets too low? If they're too low, you've got to have raised toilet seats because people who are deconditioned can't manage this. Do you have uneven surfaces? Do you have lots of sharp edges? If you had sharp edges and someone fell, they could lose an eye, they end up with a laceration. They're just awful. Or you have clutter and tripping hazards. So what can be done to be able to get rid of the clutter and do your nurse executive rounds, your leadership rounds, your environmental services rounds, get rid of this stuff and do everything you can to get cords up off of the floor. That's all environmental. And then as we mentioned, there's all kinds of individual risk factors that are inherent with the person, and making sure their interaction, their interface within the environment is safe, creating that safe exit side, helping people to be able to use adaptive equipment within reach, making sure the height's at the proper height, and the height of a bed should be different for someone who's 6 foot tall like me versus someone who's 5 foot tall. And again, making sure people have the proper footwear. And then that they're partners and that they do everything to partner with us. For those people who are cognitively alert and for people who are cognitively impaired, you got family members there, you want them to be partners. So partnership with patients and families is really important. This all gets into patient engagement. So some people will have an agreement signed by staff and a patient. It's not going to hold up in court, but it's a way of getting them to, have a sit-down conversation and say, this is the things that we are going to agree to together and work on together for your safety, and keeping everything, doing all that we can to be able to prevent falls. Understanding the consequences of anything that the teach back and having that documented. You want to have that documented in the medical record under education. But using the teach back and making sure people understand why they're at risk for falls, what are we doing about it, what happens, why it's important to call for help, as we mentioned, and what happens if they don't. Always involving the patients as partner. And then start thinking about progressive mobility. because we're doing everything we can to get people up and out of bed. We want to have an ambulation program, but being able to know how to properly toilet people before they start walking and how to make sure that this is part of the program that we plan for toileting. Someone who's on a diuretic, for example, that we help make sure that they get toileted every 20 minutes once that kicks in. And then protecting people when they're sedated. And these are patients that you want to make sure that you toilet them, assist them with toileting while they're under the influence of medication. But having people toilet before they get a pain medication or any kind of medications that are centrally active. So these are the patient factors where people with cognitive impairment. These are indeed people you want to have on a bladder retraining program or do scheduled toileting. People who need to be assisted to the toilet or people who are on bladder retraining, and it's not everybody. These are the people that you indeed want to, with cognitive impairment, is to be within arm's reach, is to not have them toilet alone. People who are cognitively intact, they have a right to say no. It's their choice, as long as they understand the consequence of that choice. But toileting before medications is really important. I think we talked about the scripting. But here are some examples. Would you like to go to the bathroom now or 1 minute from now, like I had mentioned? Or it's time for a bathroom break. You know, let this be how, make it a little joke. But let's try to go to the bathroom before you go for that walk. And these are all ways of helping people be able to do this. So with scheduled toileting or bladder retraining, you know, there are times for these two patients where indeed safety is trumping privacy. This is where you implement that nobody toilets alone, where you want them to call for help. And we still know that some people will get up without us, so you're going to do your best. But if you do that scheduled toileting, you're going to monitor fluid intake, make sure they get to the toilet every 2 hours, whether it's the even hour or the odd hour, but get this scheduled. So if I'm a nurse manager on a unit, I want this hardwired because we all know people get up without us because no one wants to have an accident. So, you know, when are you going to start? You know, what's your interval for getting this started? Do you want to get this started 6 a.m. to 8 p.m.? What is it? You have to decide on this depending on the patient and individualize it. Get them toileted before meals, after meals, bedtime. Those are all things that you want to plan. And then have your arm's length business for a patient with balance or cognitive issues. This is indeed that very vulnerable population. So we want to ask you now what your thoughts are, and maybe this will make a little difference for those of you who, or some difference for you that are trying to implement this No One Goes to the Bathroom Alone program when you think about cognitively impaired versus people who are cognitively intact. And if you might have any other questions or things that you want to share that might be some barriers that you've dealt with, we'd love to hear from you. And Martha shared a website, too, with some tools that have been able to show that are working with eliminating falls associated with toileting.
So if you guys could really chat in your barriers, because as we're getting closer to the end of this fall webinar series, we want to be sure that we address any barriers or roadblocks that are in your way of making it safer for your patients. The website there for the Hospital Quality Institute, that'll take you right to eliminating falls and the toolkits there. And the way that toolkit is set up, there are like 6 or 7 different tools that had been shared with us by hospitals within the CalHEN for things that work, strategies that work. You know, some are on assessment, some I think there's a couple on huddles, and there is one there for a patient-family agreement. So that's why we shared that there. Questions or barriers?
You're welcome. I know Martha has there's so much information to share with people. Absolutely.
So we hear those typewriters going, or I guess shows my age, huh?
Yeah. I loved it. You know, they are typewriters and keyboards, absolutely.
Right. Okay, somebody put us on their hospital music. Okay, Eileen, challenging to have different standard of work for different patients. Currently, we use the fall risk score, but maybe we should look at other issues. We are working on proactive toileting Q2 hours. Excellent. Pat, do you want to address that, or do you want to?
That's exactly right. Is you want to be able to move away from the score as a driver for action. What you wanted to do is to make the driver for action to be actual risk factors that you assess from the patient. So right here during this session, what we've talked about is being able to assess for cognitive status, mobility status, and then you're going to look at other things like medications. You know, even part of cognitive status includes ability to be able to communicate. So you want to make a decision for people who need to be on assisted toileting or scheduled toileting based on actual need, and that is your assessment, and that's what gets to risk factors. So everything you can do is to be able to individualize care is moving away from a score. Because you can have a score, but it doesn't tell you that that score has anything to do with toileting needs. It could just be having multiple medications or having multiple diagnoses. So that is a really good point, and I'm so glad that you went ahead and typed that in. You know what else, Eileen, too, is I think is really important. I think that was, let me just see, that was Eileen's message. Is the Joint Commission, when they launched that clinical guidance September 28, 2015, really for preventing falls in hospitals, moved all hospitals away from a score. You know, the screening tools that you use is what gives you a score and reduces a patient to low, moderate, or high fall risk. Well, that only is used to implement universal fall precautions, which alone doesn't work. What you want to be able to do is to know why are people at risk for falls, the individualized fall risk factors, and then the individualized injury risk factors. So for toileting, you want to make a decision for who needs to be on scheduled toileting, who needs to have assistance to get to and from the bathroom, just like new moms do. You know, people who have had surgery need help to get to and from the bathroom. So this is coming back to using your clinical judgment, which is what it's all about, rather than based on the score, because when you implement an intervention based on the score, all you're doing is implementing universal fall precautions, and that doesn't work. And again, not everybody needs help to get to the bathroom. You know, it's not for everybody. So for Karen,
Great.
She thinks the balance between setting processes in place and ensuring the processes are feasible has been a challenge. There's a balance between, setting processes in place and ensuring that, absolutely. Because trying to ensure something means is getting to reliability. So when you narrow who really needs to have this done, then you have more possibility for making sure that it gets done, because it's part of the handoff, it's in the care planning. You talk about it with the patient, you've had the conversations, you've had the teach back, you've had the same involvement with family members to know who needs to be on scheduled toileting. Yeah, on a rehab unit, oh my goodness, and a patient's going to therapy, everybody needs to know when this patient's supposed to be toileted so they can help too. So it has to be part of the handoff, the care planning process, definitely. And then you can monitor that. I mean, that's part of what you want to monitor. It's not having to monitor that everybody's been taken to the bathroom every hour, every 2 hours, as you would like a purposeful rounding. So for Will, we're using the score as a guideline too, but we can stress and move away from this, absolutely. So Eva has the toilet commode, not just the, you have over the toilet commode. Yeah, that's like the bedside commode where you just take the potty out, the pot, and then you just put the commode over the toilet. But the other ones, the fixed toilet seats, they just get cleaned by housekeeping, just like you would, you know, if you were even just a bedside commode over a toilet. So it's not that difficult to clean, not at all. The issue is mobility, because people being able to get on and off of it, which is really important. Were you going to say something, Martha?
I was going to say, I think the question is those over-the-toilet commodes. and how safe they are. And what I thought I heard you say is that really the preference would be for the seat riser, because
that's
those,
right.
that's
right.
In a false sense of security when really they aren't secure, that you need the grab bars, you need things that are mounted so that they can give more support.
Right. The bedside commodes that go over the toilet are not safe. They're not secure. And they have different kinds of armrests. The ones that I had showed you, it's a ways back there. I could go to it if you wanted, but it had hardly any armrest at all, anything to grab onto. So they have to be height adjusted. So the ones that are fixed, they're stable. They're attached to the toilet, and then you have those wall-mounted grab bars. But the bedside commodes are not fixed. And you'll find very little literature about how unsafe bedside commodes are. The only place that I found that is with fall prevention in the hospice patient population when I was doing some trying to help an oncology hospital. So the bedside commodes, if someone was to fall with a bedside commode, their risk of having an injury is greater. So you want to, we end up using that because it's what we have. So you want to be able to move away from that and do your strategic planning to really create a safer environment, because bedside commodes are not safe to really put over there. It's just our alternative. So the other issue that we learned in relationship to safe patient handling and movement is that if people have equipment there, they're more likely to use it. And that's the safe lifting equipment to be able to reduce back injuries in the nursing staff. So I like to think about that the same way with creating a safe bathroom, is if you have the proper equipment there and just have a bathroom that's already safe for someone who's debilitated, safe for someone who's had a stroke, safe for someone who's had surgery, safe for someone who's had a baby, then you're creating a safe environment for anybody who comes into that bathroom. So it's not having to just get something for a given patient. You're creating a safe environment.
So, Pat, I'd like to suggest that we move on to...
Sure.
Okay. And okay. So thank you. Thank everyone for participating and being on the call today. And thank you, Pat, for sharing all your learnings and experience and education with us. I would like to ask for the group to respond to polling question number 4, and that is staying within arm's reach of a patient while they're on the toilet is, and there are a couple different options there. A, an invasion of the patient's privacy. B, not required if the patient promises to use a call light. C, not necessary if the patient promises to wait for the nurse to return before getting up. Or D, is a safety intervention for the patient with cognitive impairment. And it looks like everybody got that, Pat. So thank you very much for participating and sharing. The next slide, let's see. Oh, yeah. So what are you going to do? So I would just challenge you to think about what you can do by next Tuesday. What can you do to help make toileting for your patients more safer than it is now? And we've talked about some very practical strategies. One, really going back to assessing that patient, like we talked about in the first webinar, and then also really engaging them in the teach back and understanding what their risk factors are. You know, making sure that your bathrooms are safe and free of clutter and have good support. And then and so next time we're going to be talking about mobility issues, walkers, and postural hypertension. So, or hypotension, excuse me. And what I also wanted to give a reminder, as you had indicated, we're going to use part of session number 5 on August 15th to talk about what is working or what's not working at your individual hospitals. And so we're looking for maybe 2 or 3 or more volunteers that are willing to share some of their stories. And I've already picked on one because actually I was at a site visit out in Palmdale last week, and they have taken a lot of that assessment criteria that Pat shared early on in the workshop and made it a very easy to follow visual for the staff. So they have agreed to share that. Thank you, Will. But I'd also like the rest of you to think about, who'd be willing to share a little bit about their stories. So if you could think about that and you want to go ahead and email me, that would be great. Otherwise, you can have great confidence that I will come and tap you on the shoulders. So, any other questions or comments?
Martha, the only thing I would say is I know we're going to you have some of the content from session 4 spilling over into session 5. So we're going to keep on this discussion about the walkers and the hypotension, the mobility, because we get into a little bit more of the mobility assessment. So this is going to be, I think, we'll carry into session 5, but we do want people to do sharing with us. We certainly do.
Great. And I saw the note there from Eileen Jensen on post-fall huddles, and we do have a format for that, so I can go ahead and send that to you, and I can also look and see if there's a link. So, great.
Yeah, we have a lot on the post-fall huddles on the VA website. We've got the tool. We've got the decision tree. It's on the VA's the National Falls Toolkit website.
Oh, scripting with the CNAs. That would be, so Lynn, are you saying that you have some examples or you need some examples on scripting with CNAs? She's still here. Or we can, maybe she's typing. Great. So maybe if someone has some examples of scripting that they've used or that they use with their CNAs, that would be great if we could share that. And if you send it to us, we can get that out to everyone. Well, I think that we'll go ahead and close the webinar. Again, thank you all for your time. Please mark your calendar for July 25th. It's only, it's going to come up here pretty quick in like 3 weeks, less than 3 weeks. And we'll start the discussion on the mobility issues, and then our last webinar will be on August 15th. So have a great day, and thank you all for your time today. Take care.
Thank you, everybody. Thank you, Shweta. Thank you, Martha.
Thank you, Pat and Shweta.
Of course. Bye-bye, everybody. Thank you.